Hi, everybody. My name is Lisa Fontes. I'm the Director of Clinical Operations for Eisenhower's Cardiovascular Center. And I have the luxury of working with these great doctors every day. So I'm very proud of that. I'm here to introduce our next speaker. It's an honor to introduce our next speaker, a highly accomplished physician who is board certified in internal medicine, cardiovascular disease, and interventional cardiology. Dr. Andrew Frutkin attended Stanford University, graduating with honors in biological sciences. He went on to complete his internal medicine residency and cardiovascular disease fellowship at the University of Washington. While serving as faculty in the university's cardiology division, he conducted grant-supported research on arteriosclerosis and cardiovascular development. Today, Dr. Frutkin remains active in research as a sub-investigator on multiple device trials and plays a key role in teaching within the Eisenhower Medical Center residency programs. Alongside his colleagues, he developed the multidisciplinary Eisenhower Heart Valve Clinic, dedicated to evaluating and treating patients with complex heart disease. Please join me in welcoming Dr. Andrew Frutkin.
Well, thank you very much, Lisa, for that nice introduction. And it's a privilege to talk to you today. It's a nice attendance, and I understand there's a good number of people attending online via Zoom, so welcome as well. I'm going to talk about aortic valve stenosis and the treatment of aortic valve stenosis predominantly through minimally invasive means called transcatheter aortic valve replacement. And this is a field when I was actually doing my interventional cardiology training at a big institute called Mid-America Heart Institute in Kansas City, where a lot of the early coronary intervention work that Dr. Khanna had just talked about was developed and perfected. Well, when I was there in the time frame of about 2006, 2008, this field was just being thought about. Clinical trials had not even been really completed or published. And yet my mentor training me on how to do complex coronary intervention said, you know, you got to look into developing skills in structural heart disease, i.e. treating the structure of the heart, the valve problems that may arise, because this will be 25% of your practice in the future. And he was pretty sage and wise and prescient, but he was probably off by a factor of 2 or 3. I would say now for myself, Dr. Khanna, our colleagues, Dr. Pangalori, Dr. Sharma, we're probably working about 50% of our time taking care of people with complex cardiac valve disease and the interaction with coronary disease and cardiomyopathy, heart failure. And so TAVR, which we'll talk about, transcatheter valve replacement, is an integral part of this process of care for patients. So I have nothing to disclose. It's relevant to talk about a number of principal people that are important for delivery of minimally invasive valve care at Eisenhower. They include my partners in interventional cardiology, Dr. Khanna, who you just met, Dr. Pangalori, and Dr. Sharma, who is the newest addition to our group, having joined about 1.5 years ago. And so we're all specialized in the field of interventional cardiology, which is the subspecialty of general cardiology. And as you've heard, we've endeavored to take on new skills, many of which we perfected and adapted after we had completed our training, you know, a decade or more ago. The cardiac surgeons at Eisenhower are extremely talented and do many different facets of cardiovascular care. That's Dr. Logston and Dr. Wilson. And then we have the great luxury of having three nurses that help steward our complex valve program. They are Crystal Gannon, who now has a managerial role in the cardiovascular service line, Julia Wood, and Tara DeGrazia. So this is a patient that actually Dr. Khanna had cared for many years, and he's the first patient we treated by minimally invasive transcatheter aortic valve replacement. And his story, now 10 years removed from when we actually treated him, 10 years, we've been doing this, a decade, it still resonates. It's still a great example. So at the time he was 92, he was active in his community, engaged with family and friends. He was still playing golf, but he was bothered by a progressive knee arthritis, not an uncommon problem at such age. And he was interested in getting knee replacement surgery so that he could keep on being active. But he began to manifest with worsening symptoms of heart failure, which may have been partially obscured by the fact that he was walking less, doing less, so he was challenging his heart less. He ultimately ended up hospitalized with this heart failure. And at that time, we refined the diagnosis that he had severe aortic valve stenosis. So stenosis means narrowing. So he had severe narrowing of his aortic valve due to scarring and thickening and calcification, mineralization of that valve over 90 plus years of life. We considered him to be medically frail, in part just due to his substantially advanced age, but also some of his orthopedic limitations. So we conferred and we said, well, you know, the gold standard for taking care of aortic valve stenosis with heart failure is to have open heart surgery. But this is a gentleman that just won't do well with open heart surgery. It'll be hard for him to recover. It's hard to envision that he'll be able to bounce back so that he can move on with life and so forth. So we actually pursued the minimally invasive approach of transcatheter aortic valve replacement, and he was the first patient we treated at Eisenhower back in April 2015. Remarkably, the following day, I'm visiting him on his telemetry unit. He's recovering, and he's up and walking around, and he's flirting with the nurses and singing show tunes and showing them how, you know, he still has some, you know, kind of modest dance moves. You know, this is a person we just replaced the heart valve. A complete change and divergence from what would have otherwise been the case had he undergone open heart surgery with a sternotomy, general anesthesia, and so forth. He went home in 2 days. His heart symptoms completely resolved. He completed cardiac rehabilitation, so supervised exercise with our cardiac nurses in our gym to get him moving again. And then 3 months later, he underwent his knee surgery so that for the next several years, he was out there playing golf with his buddies and engaged with his friends and living in his own home. I mean, a complete success story for this individual, not to mention all the people with whom he was involved in. So this was the start of our program, and now about 1,300 patients later, you know, we were able to kind of replicate this story over and over and over again for members of our community. Okay, so I'll talk about the physiology of aortic valve stenosis. Why is it a problem? The clinical course and therapy, how it had been a previously underserved or unmet clinical need, our heart valve program here at Eisenhower, and then some variations on that care, in particular, some of the newer advances in clinical trials that will change the way we as physicians identify and treat patients. Okay, so what is aortic valve stenosis? So the aortic valve is typically in a healthy adult a 3-leaflet valve. It's the last valve in the cardiac circuit. Our cardiac valves have been designed or evolved, if you will, to provide unidirectional one-way flow through the heart-lung circuit. Okay, so the valve will open when the heart muscle contracts and expels blood across the valve to the aorta to the rest of the body. As that heart muscle starts to relax and the pressures decline in that ventricle, that cavity, then the valve should return to a closed position. So it's a passive valve that opens when the heart muscle contracts, the ventricle contracts, and relaxes and closes when the heart muscle relaxes. And this allows for unidirectional flow out of the heart up into the aorta, but prevents backflow from the aorta back into the ventricle. Okay. As we age, some of us, not all of us, but some of us start to develop thickening, scarring, and calcification, mineralization of the valve. And what happens is that process then leads to restriction of the movement of the leaflets. The leaflets are just less pliable, less compliant. This is an autopsy specimen of someone that probably succumbed to the sequela of aortic valve stenosis. And you can appreciate the nodular, calcified, thickened appearance. And you could envision that it would be quite hard for the heart to eject enough volume at a high enough velocity and pressure to open those leaflets. That's aortic valve stenosis. So how does that manifest in the individual as symptoms or signs? So people will develop chest pain or chest pressure with exertion. That's called angina. That's because the heart is contracting, trying to move blood across that stenotic or narrowed valve. And because of the limitation of flow, blood can't return in sufficient amount through the coronary arteries back to the heart muscle. In addition, the heart muscle is working extra hard, demanding more metabolism, demanding more blood flow to actually generate that contractile force. So it becomes almost a vicious cycle. Shortness of breath. This is probably mostly due to the higher pressures in the heart chambers as that heart muscle is trying to contract against the stenotic thickened valve and the transmission of those pressures back to the lungs and lung receptors. Near syncope or syncope, syncope means loss of consciousness. So in extreme circumstances, there's not enough blood cardiac output leaving the heart, getting up into the aorta and the great vessels that go to the brain. So with lack of blood flow to the brain, you lose consciousness. And arrhythmia, such as atrial fibrillation, is a common consequence because of the high pressures in the heart and the effect of those pressures on the cardiac conduction system. The physician, the internist, the family practitioner, cardiologist can get a clue that an individual has aortic valve stenosis through a physical exam. Aortic valve stenosis has a very classic murmur in the cardiac phase termed systole during contraction of the heart pump. It has a particular position in the chest, what's called the right upper sternal border, because in general, the heart contracts blood across the aortic valve up into the aorta in a direction as the aorta comes through the chest. And so we can look for a certain radiation of the murmur. The murmur can radiate up into the carotid arteries. And there's a soft or absent second heart sound, which is the restriction in the closure of that aortic valve. And then there are diminished and delayed pulses, which in Latin, medical students will learn is parvus et tardus, and that is just the reduced cardiac output making it out to the peripheral vessels. So we can further confirm aortic valve stenosis through an echocardiogram. This is a diagram of the heart in longitudinal cross-section, where we have the left ventricle pumping blood across the aortic valve up into the aorta. This is the echocardiogram image of that heart pumping across the aortic valve up into the aorta. This is a normal aortic valve. This other valve here is the mitral valve. And then here is a heart with aortic valve stenosis, where the muscle has become thickened because of the need to generate higher contractile forces and pressure. And this thickened, scarred-looking valve where you can appreciate the leaflets are not really opening adequately. We can look at this same heart in a different orthogonal 90-degree cross-section where the aortic valve is sitting essentially in the middle and the heart chambers are wrapped around the valve. Here is that 3-leaflet valve, and you can appreciate with each contraction, the valve is opening and closing. We call that the Mercedes-Benz signs for somewhat obvious reasons. And here is that thickened valve. You can no longer really even appreciate the anatomy or morphology of the valve, and you can appreciate those leaflets are not moving well. Now, we not only look at the heart in 2 dimensions, we can evaluate with the ultrasound test, the echocardiogram, the physiology of the valve. So we have certain criteria that studies have established for defining severe aortic valve stenosis, and those are velocities across the valve greater than 4 meters per second, peak gradient, pressure gradients across the valve of 60 millimeters mercury or more, and mean gradients of 40 millimeters mercury. And then we can calculate the valve area through some simplified equations, and we use as a standard of valve area under 1 square centimeter as representing severe aortic valve stenosis. Now, the normal human adult valve may be a valve area of more like 3, and then even in large people, 4 square centimeters. So you start to appreciate we're talking about a reduction in the orifice area of these valves of 75, 80 or greater percent. Some people that we care for have valve areas that are calculating as small as 0.5 square centimeters, which is approximately the tip of the ballpoint pen. Now, way back, a very preeminent cardiologist named Dr. Eugene Braunwald and his postdoctoral fellow, Dr. Ross, studied about 65 patients who had aortic valve stenosis, and this was done in kind of the mid to late 1960s. And they followed these patients, and what they found is that these patients with severe aortic valve stenosis, when they manifested with symptoms, their cardiovascular health and their overall health declined. They developed angina, heart failure, loss of consciousness, and these symptoms heralded imminent mortality. So at that time, during the study, they didn't have the means to turn to the surgeons and say, can you replace the heart valve? They didn't have transcatheter aortic valve replacement for certain. So it was really an observational study of the natural history of aortic valve stenosis, and things did not end well for these patients. Interestingly, these patients were also relatively young. They were people in their mid-40s through 60s, a different demographic than we now tend to care for. But this initial study has held true over the decades. Untreated aortic valve stenosis has a very profound impact on health and mortality if left untreated, such that at 50%, if left untreated, 50% of patients with severe and symptomatic aortic valve stenosis will pass away. A 50% mortality is quite profound. And if we go out 5 years in these patients, there are only 5% of a cohort that will have survived. This turns out to be a worse prognosis as far as survival. Here's that approximate 5 to 10-year survival of 3 to 5% compared to most metastatic cancers. These are just estimates of what it might be to survive metastatic cancer for 5 years, 30%. So we're talking about a really profound diagnosis for patients. Now, fortunately, in the late 60s and into the 70s, the surgeons developed and perfected open heart surgery for aortic valve replacement. So the surgeons, even to this day, can perform open heart surgery, i.e. open the sternum, access the heart, the aorta, place the patient on the cardiopulmonary bypass so that the blood circulation is going through the heart-lung machine for oxygenation and so forth, and circulation. And then the surgeon can enter into the heart, the aorta, remove the aortic valve, and sew then in a new prosthetic valve. Here's the new prosthetic valve being sutured into place with the cannulas delivering blood back to the heart-lung machine and back to the patient. And over the years, the surgeons have perfected this technique, so now they can do it through minimal surgical incisions, sometimes between the ribs in the anterior chest, or partial sternotomies that leave the sternum intact for quicker healing. And the surgeons do this quite well, quite efficiently, and the typical estimated risk for having open heart surgery for surgical aortic valve replacement is usually around 1% in otherwise healthy individuals. And in fact, here is the curve for patients with severe aortic valve stenosis that do not receive surgical therapy. And again, here's that 2-year mark where survival is only about 50%. Here's that 5-year mark where the survival is down under, 20%, even less. But if you undergo surgical aortic valve replacement as an individual with severe and symptomatic aortic valve stenosis, you have a markedly improved survival curve, much better than not having had surgery. In fact, you return to the expected survival for someone your age with similar medical problems. Okay, so there's always been a historical problem, is that there is a large prevalence of people who have severe aortic valve stenosis. Here's the prevalence, approximate prevalence for people with severe aortic valve stenosis in the US, perhaps 1+ million people. But traditionally, annually, only about 85,000 people were receiving surgical aortic valve replacement, meaning that there was this vast pool of people with severe aortic valve stenosis that were not being treated. Well, why would that be the case? This lady here in this image typifies the patient with severe aortic valve stenosis in the modern era. Advanced, older age, perhaps medically frail. Someone's helping her up out of the chair. Perhaps she already has heart failure because the heart's not pumping adequately across that valve. Prior open heart surgery, had bypass surgery 10, 20, 30 years prior. A heavily calcified aorta, which leaves the surgeons with no place to access the vasculature for the heart-lung machine. Prior stroke, which increases the risk of stroke. Kidney disease. Once you have some kidney insufficiency, your risk of kidney failure at the time of open heart surgery markedly increases. Lung disease, such as COPD, emphysema, which would make it hard for you to come off the heart-lung bypass or ventilator. So many of our patients with severe valve stenosis have this constellation of other medical problems or advanced age that really made cardiologists and cardiac surgeons hesitant to recommend open heart surgery. Fortunately, pioneering physicians developed, and then companies took the lead in perfecting transcatheter aortic valve replacement. This is an image of the catheter delivering a balloon expandable valve into the aortic valve position. Initially, trials were performed, and the FDA said with this trial data, cardiologists and surgeons can treat people at prohibitive risk for open heart surgery. So prohibitive risk means the surgeon would not entertain doing surgery at all because of the risk of morbidity and mortality. Shortly thereafter, the FDA said, now cardiologists and surgeons can use this technology to treat people at high surgical risk. So let's say a risk estimated at over 10% of mortality for open heart surgery. And as additional trials were performed on people at lower risk for open heart surgery, the FDA turned around in 2016 and said, now cardiologist surgeons can employ this technology for people considered to be at intermediate risk. That is an estimated risk between 3 to 8% of mortality for open heart surgery, open heart valve replacement. And ultimately in 2009, the FDA turned around and said, now cardiologists and surgeons can treat people considered to be at otherwise low risk for complications and mortality for open heart surgery. So by 2019, the FDA and Centers for Medicare and associated insurers, and then all of the sanctioning clinical societies said, really anyone who has severe valve stenosis can be considered for the minimally invasive transcatheter valve replacement, with the understanding that it's less invasive and that it allows for delivery of a new valve to the actual beating heart without the need for heart-lung bypass, ventilators, and so forth. How do we deliver such technology to the heart? The standard approach is to use the femoral artery. We call that transfemoral arterial approach. We actually go through the skin down to the artery for access with needles and wires, with ultrasound and X-ray guidance. And then we can deliver our catheter all the way up to the heart over a guide wire to then deliver the valve. There are alternative access points, and over the time, we have found that the next best alternative vascular access is through the carotid artery, in which the surgeons will actually cut down to the carotid artery, then allowing the cardiologist to access the artery directly under visualization to deliver the catheter and valve to the heart, which is really the first time as a physician you perform this procedure. It's a little jarring because we think about the carotid artery as this essential artery delivering blood to the brain, and yet people do remarkably well with actually very low rates of stroke. So there are a variety of technologies out there to deliver a transcatheter valve. At Eisenhower, we use a balloon expandable valve. So these are stents or metal cages, coils made of special alloys that can be collapsed into a narrow or small column type of geometry that can be pushed through a catheter, a tube. They have a sealing skirt to prevent leakage around the stent cage. Essentially, when these are deployed, they create an open column, pushing back the aortic valve leaflets behind the stent cage. And then within the cage itself are leaflets that have been specially crafted and sewn, derived from the lining of cow's heart, bovine pericardium. There are self-expanding valves where the technology uses special steel alloy that can be collapsed and then released, and the alloy has a memory of its original shape, so it returns to that shape under a certain expansive pressure. And then inside those stent cages, again, leaflets are created to resemble the human valve, the 3-leaflet valve. And there are variations on these two types of technologies. This again is the valve that we use predominantly at Eisenhower because of its efficiency in delivery, its safety profile, and our success with the valve. This is an image of the stented valve in position in someone's heart, fully expanded. These are what are called the aortic sinuses that sit right above the diseased valve. This is a coronary artery, the left main artery that comes off the aorta. The right coronary artery is right here. So you can see the stented valve sits just below the origin of those coronary arteries that return to the heart muscle. And this is the aorta as it rises up into the chest to start branching into the great vessels to the head and neck and the extremities. This is an approximate size. It's probably the largest size balloon expandable valve on the market. So you get a sense of, what it looks like in, an adult's hands. We deliver this valve through a sheath. So it's a plastic tube that we can insert through the skin right down to the femoral artery, or as I mentioned now, the alternative axis is the carotid artery. There's a delivery system that then is passed through the sheath over a wire. This delivery system has articulation, so we can turn and twist it to move it through the aorta over the wire. There's a balloon at the tip of this delivery catheter, and the stented valve is crimped or collapsed, compressed over that balloon to create a low profile so that this whole system can be moved through the catheter up over wire into the aorta and then across the diseased aortic valve. And then that balloon can be dilated, expanded with injection of contrast volume under just manual pressure to expand the stented valve into position. This is an animation where a picture is worth 1,000 words. We've already placed the sheath into the femoral artery, into the aorta. We've already delivered a wire all the way up across the aortic valve into the heart. We have our delivery system in place over the wire. We're manipulating the system to what we call build the valve so that it's ready to be delivered across the aortic valve. We carefully advance this whole system over the wire across the aortic arch, taking care not to disrupt the aortic arch too much or calcific atherosclerotic debris that may be in the arch. We position the system, the valve, over across the wire, across that diseased aortic valve. You can see the diseased aortic valve leaflets. We can manipulate and adjust the position actually to a pretty precise location of within 1 or 2 millimeters. We will pace the heart rapidly at 180 beats per minute, which brings the heart to a relative standstill and dilate the balloon during that rapid pacing so that the heart doesn't generate a pressure and eject the valve out of position as we're deploying. We expand the valve with that balloon, opening the stent cage, pushing the old valve leaflets out of the way behind the stent cage and up against the wall of the aorta. And then we withdraw our equipment and we assess the newly deployed valve with an ultrasound echocardiogram and measurement of pressures. The remarkable thing is that with this deployment of a valve, we can take someone that has mean pressures across their disease valve of 60, 70, 80, even 100 millimeters mercury, and bring that pressure gradient down to 0 within just a few seconds of deployment of the valve, which changes the efficiency of that heart pump, the ventricle, immediately. So this is just the deployment in real life under X-ray guidance. We see the pacing of the heart, the balloon expanding that stented valve with the system over the wire. And we deflate the balloon, leaving the stented valve expanded in position with the leaflets pushed back behind the stent cage. And we can begin withdrawal of the equipment over that wire. This is the appearance of a newly deployed stented valve. You can see the 3 leaflets, the Mercedes-Benz sign, right? And here it is in long axis, the leaflets open. Again, when you harken back to what that valve looked like, that scarred, thickened valve, now with a newly functional valve. It's quite remarkable. So Dr. Khanna had mentioned we use these special sutures that we can deploy through the skin down to the vessel. So we deploy those before we put in these large catheters to deliver the stented valve. And that allows us then to control the hole or the arteriotomy we've made in the artery. At the end of the procedure, we remove this large caliber sheath, which is somewhere on the order of 5 to 6 millimeters in diameter. That's a really large hole in an artery. And we deploy these sutures down onto the artery, cut the sutures, and we're left with a closed artery and just a small puncture site in the skin. No scalpel to deploy that valve. No scalpel used to deploy that valve. So does this work? Well, in the United States, to have these types of devices approved by FDA and ultimately Centers for Medicare and other insurers, you have to show there's proof in the pudding. And so this requires clinical trials. And back now, well more than a decade, the initial clinical trial was performed to look at people with severe symptomatic aortic valve stenosis and ask the question, does transcatheter aortic valve replacement benefit such patients? The first group that was looked at were patients that were considered inoperable. These were the patients where the surgeons and cardiologists said there's no way this individual could possibly survive surgery. In other words, these were the individuals that were fated to have that rapid decline in health and life expectancy because they were not treatable otherwise at the time. And in this group, at 1 year, sure enough, if you received, quote, standard therapy, which was basically a pat on the shoulder and good wishes, your mortality at 1 year was 50%, and your mortality at 2 years was nearly 70%. These patients, half of them received the transcatheter valve replacement, and their mortality, though still high, was much lower. It was a 40% reduction, almost a 50% reduction. Their mortality overall was about 30%, and at 2 years it was about 40%. This type of reduction in mortality for any type of medical or surgical therapy has been seen in very few trials over the decades. This was a transformative result when it was published. The trial also included a different group. These were high-risk patients where their estimated risk of mortality for open heart surgery might have been 10% or more. The surgeons would enter into surgery with trepidation with such patients, and yet half of these patients were treated with surgery and the other half were treated through the transcatheter aortic valve replacement, this novel technology. And what this part of the trial showed was that, in fact, you could deliver this novel technology and achieve the same outcomes as the gold standard, which was open heart surgery. With this information, the FDA said, okay, cardiologists and surgeons can treat people with symptomatic severe valve stenosis who are at prohibitive risk with the TAVR and also with high risk with TAVR. And this is what started the delivery of this technology, opened up this field. Not long after, a few years later, trial was conducted looking at people at intermediate risk for having problems with open heart surgery. And what was found is that, again, if you underwent the gold standard open heart surgical valve replacement, or if you underwent transcatheter valve replacement, your outcomes were pretty similar with respect to stroke and mortality. And a subset of those patients that had the transfemoral approach, meaning going through the skin right to the groin for their transcatheter valve replacement, they actually, in the blue bar, had lower rates of stroke and mortality than those that underwent the traditional open heart surgery. So this was a trial that actually suggested, wait a second, TAVR is not equivalent. It may actually be better for patients. Next trial looked at people who were considered to be at low risk for having open heart surgery. These would be the individuals where the surgeon, the cardiologist say, you know, we should take care of your symptomatic severe valve stenosis, and your risk of having mortality related to open heart surgery is under 3%. Not uncommonly, we just use the same statement. It's about 1% or less. And in fact, in these patients, the risk of a combined endpoint of death, stroke, or going back to the hospital after their valve replacement was about 15% over the trial for surgical valve replacement, and it was half that for transcatheter aortic valve replacement. And every pre-specified endpoint within that trial, the findings turned out to be better for the transcatheter valve replacement TAVR than surgery, which then allowed us to say, well, listen, this is an option that really makes sense for everyone, including those people that would otherwise, we thought, traditionally do well with open heart surgery. Over the course of time, what we've seen in clinical trials is that the risk of dying because you've undergone a TAVR has declined from initial trials where it might have been at 30 days, 6%, down to updated trials where it might be as low as 1%. And that's in part because the selection of patients now favors people who might be at lower risk for problems, including mortality for valve replacement, but also because we as cardiologists and surgeons have gotten much better at performing this valve replacement, and the technology has also evolved to make it easier for us to do this work. And major complications like stroke, this was a great concern in the early trials. The stroke rate was as high as 7% for patients that underwent TAVR, and now we're down in trials as low as 1.5%. And actually, in actual practice, our data were at about 0.5% stroke rate, so very low rates of stroke. Importantly, in the low-risk patients and other patients, the same findings apply. People that undergo TAVR, the minimally invasive approach, perhaps not surprisingly, do better up front compared to people who undergo surgery. So this is a slide looking at TAVR in the dark blue and surgery in the gray. And what we see is that at 30 days after valve replacement, only about 20% of the TAVR patients still have substantial heart failure symptoms, where it's more than 30% in the surgical group still have heart failure. Now, one thing that's important to note is that if you look at patients far enough out from their valve replacements, let's say 1 year, they're doing just as well, whether they underwent the TAVR or the surgery. So longer term outcomes, people do well just having their valve replaced. And the same holds true for things like measuring how do people do bouncing back from their valve replacement. There's a test where we have people just walk. How far can you walk in 6 minutes? And the blue bar is a much further walking distance at 30 days than for the gray bar, the patients that have undergone surgery, perhaps not surprisingly. I mean, the patients undergoing open heart surgery are recovering from sternotomy, from general anesthesia, from being in bed for 5 days, recovering from surgery, all the things that set you back. What's interesting is that when you go out even a year, the people that underwent the minimally invasive approach, the TAVR, are still doing better with their walking activities and so forth than the people that have undergone surgery. So we're at a point now in this field where with transcatheter valve replacement, we can treat the person at high or prohibitive risk. This might be the 90-year-old who has reduced mobility, uses a walker to get around, dependent on other people to do their shopping and so forth. They might have other medical problems like lung disease, prior TIA, minor stroke. We can treat these people successfully. Or the person with an intermediate risk profile for problems with open heart surgery, such as the mid-80-year-old who is active, still out there playing golf, but he's got diabetes, got coronary artery disease, he's had prior coronary stents, he has some medical problems. Or someone at low risk for a problem with open heart surgery, maybe this woman here in her early 70s who's still traveling, engaged in life, doesn't have significant other medical problems, just has a valve that's dysfunctional. All of these individuals are eligible for the minimally invasive TAVR. So not surprisingly, what's happened is that since the initial approval for TAVR technology, the number of individuals being treated by TAVR has increased on an annual basis. This data is now getting a bit dated. And what's happened with open heart surgery for valve replacements kind of interesting in that it has stayed relatively steady, although it may be tailing off a little bit. So we're treating more patients all told. In the registries, we find that now we are treating people initially with high rates of risk of mortality upwards of 7%. And over the course of time, the risk of projected mortality for valve replacement, surgical valve replacement, has declined as we're employing TAVR across a wider spectrum of patients. The risk of mortality has declined. So here is like the 30-day mortality, and the bar just declines steadily down to 1 to 2% for patients undergoing TAVR. The rates of stroke have gradually declined. The national registries have the rates of stroke at about 2%. And as I mentioned here at Eisenhower, we're fortunate to have a lower rate of stroke following TAVR. This is an important note. Days to hospital discharge after one has undergone TAVR has really declined substantially as we've refined our technique and minimized what we do during the procedure and around the procedure to the patients. So it used to be patients would stay 7 days in the hospital following TAVR as we were working out how to take care of such patients. And now the national average is maybe somewhere slightly under 2 days in the hospital. At Eisenhower, we're approximating 1 day in the hospital after TAVR before going home. And the vast majority of patients go home. National registry data would say about 90% of patients go home after TAVR. At Eisenhower, we're upwards around, I think 97% of our patients go home after TAVR. They don't go to a nursing facility, they don't go to inpatient rehab, they get to go home. So our program at Eisenhower is to evaluate patients who have complex cardiac valve disease, and in a multidisciplinary approach, general cardiologists, interventional cardiologists like myself and Dr. Khanna, the cardiac surgeons, Dr. Logsdon, Dr. Wilson, and other allied fields, pulmonologists, neurologists, nurses involved. We evaluate these patients and come up with recommendations and treatment plans. So the heart valve team encompasses all of these people I mentioned. I didn't touch upon anesthesiologists who help steward the patients through their actual procedures. We'll confirm the diagnosis of aortic valve stenosis by exam, interview, echocardiogram. We'll do a heart catheterization, look at the coronary arteries, measure the pressures across the valve, confirm the diagnosis again. We evaluate each patient with specialized CT scans, a scan of the heart that allows us to measure the aortic valve, look at the aortic valve anatomy, and then also our vascular access points. We have an evaluation by our cardiac surgeon to summarize, and then as a team, we pull all our recommendations together and deliver that back to the patient. So what we have available at Eisenhower would be the traditional open heart surgery through sternotomy and heart-lung bypass, minimal surgical approaches to the same surgical valve replacement, and then transcatheter aortic valve replacement, typically using the transfemoral artery or the carotid artery. Here, again, just the images of the carotid artery that we may access. This has become a real game changer in our institution where our surgeons have adopted this approach. And so now, for patients who have substantial problems in their peripheral vasculature where we cannot access safely or pass the catheters up safely through the femoral arteries, we immediately move to a surgical approach to the carotid artery. The surgeons make a small incision, and then under direct visualization, we can access the artery with our needles and wires or catheters. And then at the end of the procedure, the surgeon sutures up the small incision. These patients do remarkably well. And among the patients we've had undergo the carotid approach, we actually have not experienced any strokes, thankfully. So at Eisenhower, we're considered an institution that employs best practices, which and we're privileged to be what's called one of the sites for a benchmark program sponsored by the manufacturer of the particular valve we use. So we have other institutions coming into Eisenhower to observe how we do our work, and our work revolves around minimizing what we do to the patient. So the minimalist approach is better for the individual patient. Less risk of complications or delay. That means we use local anesthesia at the access points the lightest of moderate sedation to keep the patient comfortable during the procedure, but allows them to wake up immediately afterwards, essentially just a light propofol drip. We do imaging with transthoracic echocardiograms, so no invasive echocardiograms, transesophageal echocardiograms. We tend to use peripheral venous access as opposed to central vein access, such as up in the internal jugular veins or axillary veins. We avoid that. We do not place Foley catheters because that's just a means of introducing infection or disrupting in men the prostate and causing bleeding. We transfer everyone after the procedure up to our telemetry unit. Very few of our patients go to the intensive care unit. Bed rest is no more than 6 to 8 hours, and then the patient is up moving, ambulating with nursing staff. And we target a length of stay of about 1 day. Some of our patients are going home well under 24 hours. So we've treated closer to 1,300 patients now. Last year, we treated 220 patients. 90+% of them received just this moderate constipation, typically a propofol drip. Our mean procedural time is actually well under 60 minutes. It's kind of closer to 50. Average length of stay is about 1 day. And most of our metrics at Eisenhower, fortunately, are better than the national registries, which is, less is more. For nurses in the audience, the patients arrive on the telemetry unit with their faster access sites already addressed by PERC closes or percutaneous sutures and angioceal devices. We target normotension when they're recovering on the telemetry unit. Some patients will develop heart block after the procedure, and so we will actually screen patients for arrhythmia at the time. We get laboratories the following day, chest X-ray immediately after. We want to get people up and moving very quickly. Patients go home typically with aspirin and a prescription for Plavix for 90 days, or in some cases, resumption of their anticoagulant. Antibiotic prophylaxis, we recommend people don't have dental work or dental cleaning for about 3 to 6 months to avoid any potential bacteria entering the bloodstream and seeding on the new valve. And then no heavy lifting for a few days, no bathtub, hot tub, pool, immersion in water for a week, and then back to normal life, basically. We let people drive a few days afterwards. So we do our valve replacements on Wednesday. People can go out into the community, visit friends, family, go out to restaurants that weekend driving. And then we follow up within 7 days after the valve replacement. People get an echo at 30 days in a year. They're referred to cardiac rehab. The vast majority of people really enjoy the cardiac rehab and find a lot of value in it. Very briefly, this is important. There was a major clinical trial published in autumn where now the question was, can we treat people who have severe valve stenosis without symptoms? So just define that they have severe valve stenosis by echo and ask the question, would they benefit from aortic valve replacement by TAVR? The trial took people and randomized them to either TAVR or just observation clinical surveillance. And there was an endpoint looking at their outcomes, and the patients who received clinical surveillance had pretty high rates of endpoints of death, stroke, or ending up in the hospital. And the patients that underwent the TAVR had a much lower rate. Most of this was driven by the fact that people were ending up in the hospital if they were being observed and not being treated by TAVR. And over the course of time, all the patients that were in the observation arm ended up getting a TAVR anyway because they became symptomatic. Most cardiologists expected this to be the case, as with cardiac surgeons. The vast majority of patients had some progression in symptoms and signs, but a substantial minority of the patients being observed actually got into real clinical trouble. So the conclusion of the trial was that patients actually who have asymptomatic, no symptoms related to severe valve stenosis appear to benefit from undergoing TAVR as soon as their severe stenosis is identified. It seems intuitive, but we now have a clinical trial that proves this. And this will change the way we approach aortic valve stenosis. We'll focus less on, are you having symptoms related to severe valve stenosis, and more on the fact that we have a diagnosis. And given that diagnosis, we should move forward with a treatment plan. This field is expanding further. There's a trial called the Progress Trial where we were enrolling patients as one of the main sites. And here the question is, should we identify patients who have moderate aortic valve stenosis and some other indication that the valve is causing their heart problems, and actually treat those patients with transcatheter aortic valve replacement? That trial will be published in a few years' time, and again, may change the threshold by which we recommend aortic valve replacement to patients. So there's a lot more to talk about, but I understand I've run to the end of my allotted time, and I want to thank you very much for your attention. Again, for those of you in the clinical field, our valve clinic coordinators are reachable and are able to get the process of evaluation going for patients, and they're extraordinarily efficient at doing so. And on behalf of my fellow physicians, we really appreciate your interest and support, and then the interest and support, the deep support that the medical center has provided so we can deliver this care to the community. Thank you. Yeah, so those are two very important questions. So the approximate answer for these types of valves are called bioprosthetic valves, which means that the functional part of the valve, the leaflets, derives from animal tissue. As you recall, I told you it was the lining of a cow's heart that's been specially harvested, cut, sewn, treated to then resemble a human valve. The data regarding longevity of these valves is mainly through the surgical type valves. It's the same leaflet technology. And we tend to tell patients that you'll have 10, 12, maybe 15 years of longevity of the valve before the valve leaflets themselves start to scar, thicken, mineralize, and deteriorate. Transcatheter valves, the current generation of transcatheter valves, we don't have patients yet that have lived out that long from their valve replacement, in part because, remember, the first patients that were treated were the patients who were the sickest of the sick patients. And so those patients that were studied in 2010 or initially treated under FDA approval in 2012, they passed away in a few years, mainly from their other medical problems in their advanced age. It's only been in the past 5 to 7 years where we're started treating a cohort of people that are going to live a long time because they were identified as having a low risk of problems related to their valve replacement and were otherwise healthier individuals, such as that 70-year-old active woman I showed the schematic of. So we are still waiting and looking at the patients we treated to confirm that, in fact, the transcatheter valves that we've been implanting will last 10, 12, 15 years. So far, everything looks great. Anecdotally, I just had a gentleman that I implanted his TAVR valve when he was about 86. And he came back and saw me with a perfectly functioning valve at age 94. So he was one of the patients that we treated really early in our series. And here he is 8 years later, living to very advanced age with a valve that looks pristine. So by all signs and metrics, things look really encouraging for the durability of these valves. So that's we would expect that kind of time frame. Now, interestingly, what would you do if the valve fails? It starts to scar, mineralize, and doesn't work properly. So with this technology, we can do what's called valve-in-valve replacement. In fact, this is a schematic of it here. where there's, in this case, a surgical valve, maybe put in 10, 12 years ago that's no longer functioning properly. And we can deliver the transcatheter valve and use the surgical valve as the anchor and push back the old surgical valve leaflets and create a new valve with a new stented valve. And we can do the same with a transcatheter valve within a transcatheter valve. So now when we talk to patients who are young enough in their 70s, early 80s, we're already thinking, what are we going to do 10, 12, 15, or 20 years down the road when maybe this individual is still living relatively well, surviving, but their valve has deteriorated. And so the valve and valve replacement becomes a solution to that inevitable wear and tear on the valve. Okay, costs. So that's a little harder to parse out, but there are these kind of weird things that happen with costs and finances in medicine and surgery. Turns out that a surgical valve, I'll give a rough estimate, may cost the hospital $4,000 to $5,000 to purchase. These transcatheter valves are about 6 times the cost. So, but the patient who's having surgery stays in the hospital for 5 to 7 days. And every day in the hospital is a very expensive proposition for that hospital, as far as the nursing care and other ancillary care, the physical therapist and so forth, just the bed, the lights and so forth, the medicines. Whereas the person who gets the transcatheter valve is going home the next day. So in the end, the costs probably even out for the hospital, the medical center delivering them. And the insurers have calculated a way of paying back the hospital to make the hospital whole and provide a little bit of extra money so that, the hospital maintains the care delivery to the. It's not an inexpensive proposition to do this type of work for a patient, at least up front. Now, there's a whole field of medicine and surgery where they look at what's called cost efficacy. So if Medicare spends, let's say, $60,000 on having a patient receive aortic valve, what happens down the road? And what happens is that in a very quick period of time, you recoup that cost because the patient's not coming back to the hospital with more hospital admissions. They have a certain productivity in life and so on. And these technology, surgical aortic valve replacement and transcatheter aortic valve replacement, tend to be very cost-effective strategies for delivering care to patients. Any other questions? Yeah. Yeah, so that's an excellent question. So the question is, does TAVR have neurovascular effects or other neurologic effects on the patient? So fortunately, the delivery of TAVR, whether it's through the femoral artery or the carotid artery, has relatively low rates of stroke, as I mentioned, somewhere in about disabling stroke, about 1% rate of stroke. And the stroke mechanism is thought to be either disruption of plaque or debris that may be in the aortic arch as you're passing these large catheters and the valve to the heart. Some of that debris making its way up into the brain circulation. The other possibility for stroke is that when we deploy these valves against the calcific mineralized native valve, we're actually cracking and fracturing some of that calcific debris as we're opening up the valve, and some of that may move to the brain circulation. As far as impacts on cognitive function, it's interesting. This has been studied extensively with surgery and to a lesser degree with TAVR, and it's very hard to discern any adverse impacts on cognition. So patients, as a group, don't tend to have worsening of dementia and so forth. We do like the idea that we can deliver TAVR without utilizing general anesthesia or very deep sedation, because for patients with some impaired cognition or just some problems with memory, using less sedation tends to let them kind of come back to their baseline cognitive function a little more quickly with less disturbance. And so that probably is to their benefit as opposed to going under deep general anesthesia that surgery requires. Anyone else? Right. So I was just mentioning, in fact, this diagram that's looping over is an example where we can do the valve-in-valve replacement. And so we more often than not know the type of surgical valve that was implanted, the size of the valve, diameter, and having identified that this surgical valve implanted 10 or 12 years ago may be is stenotic with leaflets that are thickened and not opening, or perhaps is regurgitant because one of the leaflets is now stuck and the flow is moving back from the aorta to the ventricle. We can say this is a valve that needs to be replaced. And if it is of adequate diameter, we can deliver a transcatheter valve, such as one of these balloon expandable valves, into position. And it actually requires less imaging at the time of the procedure because we often have the surgical valve ring easily identified under our X-ray and fluoroscopy as a marker as to where we want to land our new valve. And we can do this type of valve replacement very efficiently within about 30 minutes. And the new valve implanted tends to work just as well as if we were implanting it into a native valve, a disease valve. Any other questions before we wrap up? Well, thank you very much for your attention and interest. Been a privilege talking to you.